My name's Dr. Anita Cairns. I'm a Paediatric Neurologist at the Queensland Children's Hospital, and I've been invited to talk on caring for a child with muscular dystrophy, challenges, supports, and what's changing in care and research. I'd firstly like to acknowledge the traditional owners of our lands on which we have the privilege to work on, and for me that's the Yagara and Turrbal people. We acknowledge and pay our respects to Aboriginal and Torres Strait Islanders, elders past, present and emerging. So first of all, I'd like to start with the message, and that's be kind to yourself. Parenting is hard. Parenting a child with a disability adds extra emotional and practical loads. Your health and well-being matters. You can't support your child if you're not looking after yourself. It's okay to perform in the middle of the bell curve, to be average. You don't have to be in the top 10%. You don't have to do therapy every day and get the child to wear their night splints every night. It's okay not to be able to manage to do all of that. You need a support crew, and you need to avoid those who judge or comment from the sidelines because they're not helpful for you. Reach out for help, whether that's health professionals, therapists, family, friends and teachers. There are people out there who will be willing to be on your team. So what are the challenges? So I thought I'd start with a little bit about evidence-based management, evidence-based medicine, and try and give everyone a little bit of a feeling for understanding why evidence matters. So in medicine, we talk about evidence-based, peer-reviewed science, and I think it's really important for everyone to have a bit of an understanding of what that involves. So evidence-based, peer-reviewed science means that experts have checked the information looking for flaws, bias, missing data or exaggerated claims, avoiding studies that are too small to be meaningful, so single case reports of one patient, or what we call anecdotal evidence, people saying, oh, well, I tried this and it seemed to work. Claims based on research, on results that have been misinterpreted, and this can happen especially with pharmaceutical companies because they want their drug to work, and sometimes the way they review the data, whether that's deliberately or accidentally, is not very balanced. Research funded by groups selling a product, such as drug companies. So obviously, if you're a drug company and you're wanting to promote your product, you're going to do, if you sponsor studies, those studies are likely to have a degree of bias. There are ways of managing that, but they just have to be done carefully. And social media experts with no qualifications. So everyone's aware on social media, there's a lot of people out there claiming to know things or be experts, but you really need to be looking for information that's come from people who have done these things scientifically and properly. So why is this important? Well, this is important because we want to keep your child safe by avoiding harmful, untested or misleading treatment. We want to prevent false hope by promising miracle cures, and there are people out there selling products who will happily take thousands of dollars off you with no backing or no research behind them. We want you to feel that you can trust experts who have checked the research. And we want to give you the ability to question, choose and advocate with confidence when you know that the data is real and not influenced by bias or flaws or missing data. So the other topic that I get asked a lot about when I'm in clinic is behaviour. Now, behaviour in neuromuscular conditions can be very challenging, and that's due to a number of factors. Children have physical limitations. They use mobility aids such as orthoses or wheelchairs that make them look different. They're often unable to participate in activities with their friends or classmates or because of their physical limitations. They have additional homework activities such as therapy, stretches, or wearing splints, which their siblings or peers don't have to do. They may have communication difficulties, whether that's due to weakness affecting the muscles of talking, or whether it's because they have speech and language delay as part of their neuromuscular condition. The other thing is that often children with neuromuscular conditions have caring adults who really want to help them, but that doesn't give them the ability to learn and make mistakes for themselves. They can have associated mental health issues, and this is the result of awareness of differences between themselves and others, and this can occur quite young, even in the preschool years. There's social exclusion, whether that's because of their physical limitations or because of children being not understanding or being unkind. They have reduced independence and reliance on others, which means that singles them out from everyone else. There is often anxiety about their decline, their physical decline that they're aware of. And they may have other conditions such as anxiety, depression, or OCD, some formal mental health diagnoses. One of the factors that I have seen is children not being informed of or fully aware of their diagnosis. Now, I don't mean that every 5-year-old should know that they might have a life-limiting condition, but they do have to be aware that there is some reason for them why they can't perform the same as their peers. If they aren't aware, it provokes feelings of confusion about their body and why it doesn't function. They might blame themselves for their inability to perform like their friends and think that it's because they're not trying hard enough or working hard enough. And often children do have a sense that there is something wrong with them and that adults aren't telling them the real story, and that can bring in feelings of shame or fear, because they often are more worried than they should be about what's happening to them. And so, I really strongly support parents being honest with their children and telling them the diagnosis, even though that might make them feel anxious or concerned, that, they want to protect them. We understand you want to protect your child, but in fact, not letting the child know their diagnosis is actually harmful, not helpful. And the other things that can affect behaviour in neuromuscular conditions is other diagnoses such as autistic spectrum disorder, attention deficit disorder, and intellectual impairments. And these are obviously aspects that need formal diagnosis, and is the reason why you should be linked in with a paediatrician, and also have formal, if there's issues with learning, is a formal cognitive assessment to ensure that the specific issues are recognised so that support can be put in place. So what can you do to help behaviour when it's challenging? Children really respond to routines. So having a good routine in your day, a set time for getting up, set bedtime routines, set mealtime routines, set routines when you do their stretches or put on their night splints, and all that can help them get into have a feeling of security and an understanding. And if you're the sort of child who's anxious or got some obsessional traits, then having a routine provides some security that you know what's going on from day to day. Use simple, clear instructions. Please put on your shoes, as opposed to please put on your shoes, get your bag, pick up your lunchbox. If you give multiple instructions, in children who aren't very good at processing, they get confused and they don't know what's happening, and they can get anxious and angry about that. Offer controlled choices. Not, do you want to put on your night splints, but would you prefer to wear your night splints when you're going to bed or while you're watching TV or playing your game? So give them choices where they don't really have choices, but that makes them feel empowered and is less likely to create problems. Fatigue is a big issue in neuromuscular disorders, so you need to plan for that, and have frequent rest breaks with reduced time spent on tasks or activities. So don't expect them to sit there for an hour doing something or participate in an hour of therapy. Give them breaks so that they can recover between times. Adjust before behaviour escalates. So keep your eye out for those little clues that you go, we've gone too far, let's do something different. And watch for the early signs, which may be things like increased frustration. Teach them to use their words to express what they need or how they are feeling. And so sometimes you have to help them with that. If they're feeling, if you can see they're angry and upset, say something like, I can see you're feeling angry or upset. Why don't we do X, Y, and Z? Support them in regulating their emotions. Speak in a neutral tone and don't lecture them when they become distressed. They're not going to take stuff on board if their emotional level's up here. And give them strategies when they feel overwhelmed, saying, right, I can see you're feeling a little bit angry or anxious. Why don't you pop off to your bedroom for a little while and just give yourself some quiet time? Give them space or to try or allow them to make mistakes. So don't jump in to rescue. Just give them a chance to do for themselves. Children like to be independent, and if you're always helping them, that gives them a feeling that they're not good or worthy enough to try things. And do that by doing graduated prompting. So start off with a gesture and then maybe give them a verbal clue and then help them physically. Have the same rules for everyone in the house or the classroom. Don't give them special rules just for them. Even though they might have extra chores to do, their chores might be doing stretches, whereas another child's chore might be doing the washing up. And that's, they're both chores. And if you need to get professional support through the paediatrician, psychologist, occupational therapist, through a parenting support. Exercise in neuromuscular disorders is really important. Play-based activity is more important than therapy, especially in the younger years when they're more physically able. There is really good evidence that low to moderate aerobic exercise is beneficial. So the use it or lose it principle applies in neuromuscular conditions at all. And gentle activities, walking, swimming or hydrotherapy, stationary cycling, things that they can do and manage without getting too fatigued. The benefits are clear. Exercise maintains joint range of motion and prevents contractures. It improves fitness and endurance, encourages social inclusion, and there's improved mental health and confidence. And you can engage the children in therapies through sporting wheelies. And I've got a picture of our Poweroos, who are our wheelchair soccer team there. So what do you avoid in neuromuscular conditions? You need to avoid exercises that cause additional damage, especially muscular dystrophies. So isometric exercise, so those things where you hold your muscles still while working hard. So balancing for prolonged periods on one leg, doing statue games where you hold in a particular position, planking or bridges. High resistance activities such as pushing or pulling against a strong force, so weightlifting, running up hills or stairs, or carrying a heavy bag around school. And also you need to look out for that fatigue. Do short, frequent activity rather than prolonged activity. So you don't want to do an hour of exercise. You might do 10 or 15 minutes, have a break, and then you'll do a bit more. Go down the park, go for a walk down the park, have a rest, play on the playground, have another rest, and then come home. Therapy intensives can cause significant fatigue. And the way I like to look at it is if you went to the gym for an hour every day for 2 weeks straight, you would feel really tired and have sore muscles. And the same is the same for children with neuromuscular disorders. So just be careful around those intensive therapies where there's not a lot of evidence base for those things, but they can cause additional fatigues. And I've just put the link to the sporting wheelies up there. All right, my next topic is support. Who can you reach out to? So where do you find help? Many of you may already know all of this, but there's a lot of organisations out there who've got who are there to support. We've got some really good support organisations in Australia that can help with neuromuscular conditions. Obviously, we've got Muscular Dystrophy Queensland, Save Our Sons Duchenne, the Duchenne Foundation, SMA Australia, CMT Australia, and they're organisations that are out there to support families. There's also some general support organisations such as Rare Voices Australia, which can also be helpful. There's UK and US support organisations, but just a word of warning for those, there's often treatments or organisations that aren't the same as in Australia, so they might offer advice that's slightly different, but they often have really good information about research. In education, there's a lot of information that's available. Education Queensland therapists are available through schools. There are individual curriculum plans to support children who've got learning disabilities. Specialist disability support services can go into schools and they provide therapy and equipment, and your school should be able to help you with that. And there's the Early Childhood Development Program, or ECDP, which helps with transition to kindergarten and school. And I encourage people to reach out to those organisations and your schools to get those supports in place. I'm sure everyone knows about the National Disability Insurance Scheme, but this is a funding and provides government funding for those with a disability to improve their quality of life with funding for support and services. And they will fund reasonable and necessary support. So you need documentation, and that's often letters from your reports from your therapists and doctors. And they will deem what's reasonable and necessary. Sometimes they don't make the right decisions, and there is avenues to appeal that. But you also have to be careful that you're asking for what's reasonable and necessary. So they do have rules around what parents should be providing. So they won't necessarily provide a support person to do therapy every day with a child, because some of that they would expect the family to provide. There's also support from your neuromuscular clinic where the medical specialists and therapists are there, and there's often a contact person to help you there. Your paediatrician, your mental health organisations such as psychologists and psychiatrists, and I've put a link to help you find psychologists. And just a word of warning, in NDIS, if you want a psychologist to help with your child, you need to use the term psychology to help to adjust to disability, and that's a phrase that will hopefully help you get support. You've got your community therapists, and obviously Muscular Dystrophy Queensland have got some excellent supports there. You can get behaviour support, and I've put a link to the Triple Peer Parenting Program, which provides some basic information to help support parents, and obviously carer support. So Carers Gateway, the link I've provided there as well. And again, you may know some of those organisations, but some of you out there may not be aware of them. And there's also other information. So if you want information about your child's specific condition, then there's another number of places where you can find that. Treat NMD have got some really excellent resources. Gene Reviews is a website where you can look at information about some specific conditions. It's designed for medical, so it can be quite detailed, but if you're looking for that sort of information, it's an excellent website. AusNMD is a website that also has some useful information, especially for families with boys with Duchenne muscular dystrophy. And clinicaltrials.gov is a place where you can find information about clinical trials. So if you're looking for clinical trials, then that's a place to look. So what's changing in care and research? So I just wanted to start with a little bit of information about clinical trials and what they mean and how they run, because a lot of people, you see stuff in the media or you see stuff online and you go, that looks excellent, when is it going to be available to me? I want it now. And often it's not going to be available now. So there's a number of stages to clinical research. The preclinical phase is those early lab and animal studies to check if a treatment's worth trying out at all on humans. And that can take many, many, many years and have lots of ups and downs before you get anywhere. Phase 1 clinical trials are the very early trials that are done in very small numbers of people. And these are people often with who are healthy volunteers or adults with usually the advanced stage of the disease. And it's basically to check safety, to make sure you're not going to harm or kill someone by using the treatment. Phase 2 is the trials that we normally start to involve children in. And so these are is the stage where the trial is being done on people who have the condition to actually see whether the treatment works and find the best dose. Phase 3 trials are those stages at the next level on, where they're done on large groups with the condition to confirm the effectiveness and compare with standard care or placebo. So placebo is using treatments that don't have any active ingredient. And then you get to the stage where, and then the following stage is phase 4 or post-marketing. So once a treatment becomes available, we don't stop looking at it there. We continue to look, because once you expand access to a treatment, then you find out whether there are side effects that you didn't see in the smaller numbers. So that's also very important. And those stages can take a very long time to get through those stages. So often you get to phase 2 trials and the treatment's showing not to be effective, and they have to go back to the drawing board again or go back to phase 1 studies. So this whole process, there's all these ups and downs. Oh, there's a new treatment. Oh, it hasn't worked. Oh, there's a new treatment. Oh, it hasn't worked. So, you often get this emotion that, we all really want something to work, but it may not be effective. So it's really important for these trials to be allowed to run to get the evidence that shows that treatment is effective and safe. This is a question I get asked all the time. Why can't my child access treatments available in the USA? You can see all these things online that are available in the US, and we don't have access to them in Australia. And that's because of the way that the different systems work. So in America, the Federal Drug Agency, the FDA, uses accelerated or conditional approval to approve medicines when there's really early evidence that suggests that they might work. So that's the phrase to be aware of is that might work. So they haven't been shown definitely to work. And so these approvals can be based on surrogate markers like increased dystrophin and muscle biopsies, rather than waiting years to actually determine that it slows progression of disease or it improves their function. Companies must still run confirmatory trials to prove the treatment truly works, and the FDA can withdraw approval if the evidence doesn't support benefit. And we've seen this with a number of treatments in Duchenne muscular dystrophy, where even some of the gene therapy treatments where they've had conditional approval and then they've pulled that conditional approval. The other thing to remember is that in the US, medicines are funded through a mix of private insurance and government programs like Medicare or Medicaid, which is only for eligible patients, so low-income families, and they cost much, much more than they do in Australia. So they actually go through a process that's actually more difficult to access medicines. So in Australia, what we do is there's no conditional approval, and treatments must have full evidence requirements before approval. And that's not necessarily a bad thing, because we know that they're safe then, that we know that they're not going to cause harm. In Australia, the Therapeutic Goods Agency, or TGA, does the same job as the FDA, and they check safety, quality and effectiveness before allowing a medicine to be approved. And once a medicine goes through the TGA, then it goes through to the Pharmaceutical Benefits Scheme, or PBS. And that decides whether a medicine should be subsidised based on how well it works and whether it offers value for money. So if it's a very high cost medicine that's not really a very high benefit, then they may not approve it. And so you may have this situation where a medicine's available, but no one can afford to use it. So this two-step Australian process, the TGA and PBS, means that fewer drugs are approved and subsidised compared with the USA, but that the drugs that are approved are available equitably to everyone, and we know that they're at that more advanced stage and they're safer when they're approved. So what's involved in a clinical trial? I have families who are really keen to be involved in a clinical trial, but I can tell you, my I try to talk people out of clinical trials because I know how much work they are. So a clinical trial is a way of testing new ways to prevent, diagnose, or treat a condition. And it's to help doctors learn how well a new approach works and what the side effects it may cause. So this is the way we gather evidence-based information. The benefits, if you're in a clinical trial, the benefits to you include that you might have early access to treatments that work. You get increased monitoring because as part of a clinical trial, you have lots of visits to the hospital. So that's make things safer for you. And it contributes to future medical advances, which is always a good thing. But the risks include side effects of the treatment, which could cause serious injury or death. There's extra tests, lots of blood tests, extra physiotherapy assessments, x-rays. And for a small child, a child of 6 or 7, having to go through all these extra tests and assessments, it's really hard work for them. There's an inconvenience of frequent trips to hospital. So if you've got a full-time job, it's really hard for you to be involved in a clinical trial because you might have to take 2 or 3 days off a week to be able to participate. Some of these clinical trials are for weekly infusions, and so parents and children have to come up to the hospital once a week and spend all day at the hospital. Participation in a clinical trial is always voluntary, and there's an informed consent process, and the option is you can leave the trial at any time without affecting your standard medical care. So that's really important to understand. If you say no to a trial or you decide halfway through, that won't affect how the doctors look after you. Clinical trials have very strict eligibility criteria, which means that you may not, or your child may not, meet the requirements to participate. And those criteria are set by the people running the trial. And so it may be if they can't walk, or they can't walk 10 metres in this period of time, or they can't lift their arms above their head. So there's very strict criteria. Most trials have limited places and high demand, so even eligible patients may miss out on a spot. And this is particularly true for multi-centre international trials, where they usually start the trial in the USA, and so there's often more people recruited from there than Australia. And I've just put a link to a consumer guide to clinical trials that gives you some information about them. So here's a list of disease-modifying treatments that are available in neuromuscular conditions. So there's a whole heap of new treatments. Some of these are genetic, some of them are immune-based. So many of you would have heard about exon skipping, which is a treatment that is seen in Duchenne muscular dystrophy, and some of the other muscular dystrophies are looking into. So exon skipping is a way of helping the body make a shorter but partly working muscle protein to slow disease progression. And these are treatments that are designed for particular parts of the gene. So in Duchenne, you'll have an exon 44 skip or an exon 53 skip. And so the treatments that are available are designed for specific mutations and not necessarily available for everyone who's got muscular dystrophy. And I'll put some examples there. Gene therapy is where you deliver a healthy copy of a faulty gene so cells can make the missing protein. And that's delivered with a virus vector, a viral envelope, to get that to every cell in the body. And in DMD, examples of that are delandistrogene and a forwardistrogen. Forwardistrogen has been withdrawn. And SMA on asemnogene or Zolgensma has been very effective and works very well. And I'll explain with the difference why it works so well in a minute. There's nonsense read-through treatments, and this helps the cell to ignore a premature stop signal so it can make a more complete program. And an example of that is ataluren in DMD, which unfortunately has recently been withdrawn. There's the HDAC inhibitors, which help improve muscle repair and reduce muscle inflammation by adjusting cell signals. And an example of that in DMD is givinostat. There's steroid analogues. And these protect muscle strength like steroids, but with fewer side effects. And many of you would have heard of vamorolone in DMD, which again is not available in Australia. There's monoclonal antibodies, which target immune or muscle pathways to reduce damage and fibrosis. and an example is Parmavulimab. As you can see, the drug names are really difficult to say, and that blocks a particular pathway that helps reduce fibrosis or scarring in muscle. And then RNA splicing manipulation, and this works by correcting how RNA, the signal down from DNA, is edited so the body can make a more functional protein. And we see this in SMA with nusinersen and risdiplam. We're just talking about gene therapy in DMD. So the way gene therapy works in DMD is it uses a viral vector and that viral envelope. So the viral envelope can only carry about 5 kilobytes of genetic material. But the DMD transcript is 14 kilobytes. So it's like, you go on holiday and you're trying to put something in your bag and it's way too big to fit in your bag and it just can't stuff it in. So what some very clever scientists have done is they've made micro and mini dystrophin. So they've cut off big chunks of the dystrophin gene and made these smaller, what we call transgenes that can fit in that viral envelope. So this is why you can't cure Duchenne with gene therapy. It's because you're only delivering a small amount of the genetic material to help produce the protein. The other problem in muscular dystrophy is that they don't last forever in muscles because the transgene or that genetic material sits outside the chromosome and gets lost as the muscles naturally repair and turn over. And so there's concerns that the therapy won't last forever. And the other problem is that once you've been exposed to the AAV9, you can't be given a second dose because your very clever immune system will mop it all up too quickly for it to work. So there's some challenges in delivering therapy to muscles that we don't see in SMA, where the therapy's been very effective, because in SMA it targets nerve cells, which, the nerve cells you're born with are the nerve cells you die with. So they're there for life. There are significant side effects with gene therapy. So you can get the immune response to the virus capsule, and this is the stuff that occurs early on, immediately after you've had gene therapy, with vomiting, temporary liver damage, low platelets, and this condition called thrombotic microangiopathy, where you get reduced blood clotting factors as well as kidney damage. And then there's this longer term response, which may occur weeks or months or even a year after treatment, where you get an immune response to the dystrophin genetic material. So in boys with Duchenne, they're not used to having dystrophin, and so this dystrophin genetic material is seen as foreign, and your clever immune system, which isn't so clever sometimes, recognizes and then responds in a way that causes damage to muscle and the heart, which can cause illness and death. And obviously, the last thing we want to do is give a treatment that's going to cause more muscle damage. And unfortunately, there's been 2 deaths due to liver failure and with delandistrogene, and 1 death with fortadistrogene. So at the moment, they're going back and looking at those deaths to understand what's happened, because obviously the last thing we want is to give a treatment that's going to cause a young person to die. The other issue is that clinical trials to date have failed to show very clear clinical efficacy despite high levels of dystrophin in the muscle biopsy for delandistrogene. And that's despite FDA approval. So again, the treatments look like they should work, and we're hoping they work, but we haven't really got really good evidence that they help improve function. These drugs are really high cost. So the drugs cost $3.2 million US. So obviously what you want to do is ensure that there's clear benefit before you get Australian approvals. All right, so this is my final message, and I'm sorry I've gone a bit over time. So my final message is trust yourself. You are doing a good job. Trust your child. Provide them with the tools they need to navigate their disability. Trust your health professional. We're here to help, but also you have to trust that we've done the training and we have the knowledge to help support you. There's no such thing as a stupid question. We want you to ask questions because we want you to understand your child's health care and how it works. Don't let the NDIS get you down. It is tough. It's really tough, and it's getting tougher. And you just need to have good supports around you to help navigate that. And, advocate, appeal, write to your member of parliament if you're having problems. Rely on evidence-based science and not false hope. We want things to work too, but we're not going to offer treatments that we know aren't going to work or are just anecdotal evidence. People think that they work because they want them to work. And we know we want you to have hope, but we don't want you to put your hope and money into false hope. Disease-modifying treatments are the future, but they're the future. Don't forget to focus on what you can do in the here and now. And so, things like therapy that you do now can help support your child in the future as well. So don't just rely on there's these treatments coming. You need to do things now. And clinical research trials are really hard work for everyone, for us included. It's okay to wait for the treatments to improve. Don't feel you're not doing the right thing by not participating in a clinical trial. So then I'd like to thank everyone for listening. And I'm sorry I can't be there to answer any direct questions, but please reach out to MDQ and they can send some questions through later. Thank you.